She said, I'm Michelle. I think we know most of the people in here, but let's still go around, and I just want you to say your name, what unit you're working on, and what experience you have. And if you have any, right off the bat, something you want to learn in this class. So go ahead, you can start.
My name is Simi, CCW new grad. Stephanie, CCW new grad as well. Lauren, CCW new specialty.
Janelle, CCW new grad.
Tyler, CCW new grad.
Julie, CCW. Jennifer, no longer new grad because of
Okay.
graduation. So a little over a year.
Courtney, new to CCW, but I have about a year of experience.
I'm Clinton Addison, 2 years experience on CCWS.
Terry, CCW new to specialty.
Hello, Linda.
Oh, y'all don't want to know how. Linda Bradshaw, 4 West. I've been a nurse for 42 years. But we get the vents on our floor, and I just want to learn.
That's awesome. I'm happy you're here.
And how long have you been at this hospital the whole time?
No, 30, it's going on 36 years.
Oh,
I've been
wow.
here.
If you ever walk through the tunnel, there's a gorgeous picture of Linda in the tunnel.
Oh, really?
Yeah.
The
Take a
walk of
picture.
shame, we call it.
When was that picture, Linda?
That was probably like 15, 20 years ago at least. Yeah. It's a younger version of me.
Yeah. So,
Yeah.
anyway, well, thank you guys for coming. I know it's after lunch, so we do have a little basket of sugar in case you needed to stay awake. So help yourself to that. We can just stick it on the tables if you want to pass it back and forth or whatever you need to do. If you have to get up and go to the bathroom or need to get up and stretch, just do that. Like, you know, feel free to do whatever you need to do. If there's questions, just ask. Okay, don't hesitate to ask anything at all. Some of the stuff we'll talk about is very basic, but there's a reason why we talk about everything that we do. So just bear with us with some of the stuff you're thinking, oh my gosh, why are you talking about that? Okay. So at the end of this course, you should demonstrate understanding of oxygen delivery systems, artificial airways, invasive, non-invasive ventilator support, including ventilator modes and settings, alarms, issues, and appropriate interventions, apply knowledge of mechanical ventilation in different clinical scenarios, verbalize the significance of waveform capnography, and document appropriate ventilator information in Epic. So this is one of those things that I'm talking about that can be something that you say, oh my goodness, why are we even talking about this? But it's very important to recognize oxygen and airflow meters. One of the times where it really can become an issue is like in a code when we're just in a hurry and you want to hook that bag up real quickly. You always want to look for the green. Make sure any oxygen device is always hooked to the green. Basically, the only time we use the yellow is sometimes for like our nebulizer treatments and some of our machines. Okay, as basic as that is, it happens. We'll talk about later the ambu bags and how sometimes they're even not hooked to oxygen at all, and you just look and see a nasal cannula or something hooked and you assume that's it, but we have some ways that we're going to solve that problem as well, okay? Nasal cannula. So what do you guys know about the nasal cannula? How many liters can you put it up to?
6 liters.
Okay. And when should you put a bubble jar on it?
Just to prevent the acid from drying out, so you need some notification.
Right. What if you go in a room and someone's on a cannula and you hear a really high whistle? What does that usually
It
mean?
means that they're pressure.
Pinch off somewhere.
Right, exactly.
The bed's laying on it. Yeah, somebody's rolled something.
Exactly. We were walking through the unit the other day and we heard this really high pitched whistle. And we said, what is that noise? And it was a nasal cannula was pinched under a patient. So if you hear a really, really high pitched whistle and someone's on a nasal cannula, it's usually that the tubing is pinched somewhere. So beware of that. As with a lot of our equipment, we really, you'll hear me say this about several things, we really try to pay attention to skincare. So our cannulas are very soft. Be mindful when your patient's on oxygen for long periods of time that you're looking behind the ears. Make sure there's no breakdown. Gauze is not a good idea to put on the nasal cannulas. If there's breakdown, we actually have little pads that we can put on it. We don't have as much of a problem anymore with this cannula. You can pass it out so you can feel it. And then for every liter of flow that you add to the cannula, that's basically adding 4% of oxygen. So if we dummy our math down and say room air has 20% oxygen, and you add 2 liters to it, then it's like 28%. Does that make sense to everybody? The phase 10, has anyone ever seen the phase 10 being used? For what type of patient? Do you remember? No. So why do you think we would use a phase 10? So the phase 10 looks like this. Doesn't really help with that too much.
Okay.
That's okay. That's good answer.
No,
No, what if you have like a nasal surgery?
Exactly. Yeah, perfect. Some sort of nasal surgery, nasal packing, any kind of trauma to the face, somebody that's very claustrophobic, all those kind of answers. We do not use this very often at all. You won't see it very often. Yeah, and we used to use it a little bit more than we do now. But this is something to be mindful that we do have, just in case you have a patient that for some reason it would be difficult to put any kind of mask or nasal cannula in. And a lot of times it is a surgical patient or a patient with some sort of facial trauma. Okay?
Or someone who's just claustrophobic too. Sometimes if you can't, it's a patient who's just doesn't need a ton of oxygen, but keeps taking off their nasal cannula or keeps taking off their oxy mask and just like doesn't like anything touching their face and they only need a little bit of oxygen. Sometimes that's a good option. Or if someone just needs humidification too to prevent drying, but can go on room air, you could hook that to room air, but give them humidification. So those are other.
And the downside to that is you're not going to know exactly how much oxygen they're getting, right? Because it's just kind of open to air. So it delivers somewhere between 21 and 40%, depending on the liter flow. So the oxy mask is newer to our facility. Has everyone used it and seen it? So with the oxy mask, there's a little tab here that kind of tells you on this many liters, this is the approximate FiO2 that you're getting. One of the reasons that we're using the oxy mask so much now as opposed to the non-rebreather is you can turn this down and titrate the oxygen without causing CO2 retention. With the non-rebreather, we were having episodes where liter flow was being turned down, the bag wasn't being inflated, and CO2 retention could happen, right, as a possible hazard. With this mask, there's ventilation holes, so you can turn it up and down and not be concerned with that. It's much easier to titrate. Okay, so you can see that we can go anywhere from approximately 23 to 26% up to about 83%. Just want to make sure it's well fitting over the nose and mask. And then anywhere between, like I said, 1 to 15 liters. And pass that around so you can look at this little tab here. This one's been kind of worn a good bit. From a respiratory standpoint, we can just pop that tubing off and stick the nab right in that same mask, so it's helpful for us also. Have you guys that have used it? Do you like it so far?
I love that.
Yeah, good.
Yeah.
Good. The large volume nebulizer, we used to use all the time post-extubation. We don't do that so much anymore, but we do use it sometimes for patients. Will you tell me, why would we use it? When have you seen this hooked up? And you'll see it either, you can see it with just a regular face mask at the end of it. Trach collar, right? You hook a trach collar up to this. For any other reason? If someone needs a lot of humidity, right? Humidity, this is good for humidity. For drying mucus plugs. Basically, anyone that are just really, really dry, that they need a mask, we can use this. This blue top, we use up to about 50 liters. If they need more, 50%. If they need more than 50%, we switch to the green top. The green top is just a higher flow system. So it's the same setup, okay? So it's anywhere with this blue top, 8 to 15 liters per minute. And as I said, it can have a mask or a trach collar attached to it. The Venturi used to be probably one of the most popular masks before the oxy mask came along. We seem to be using the oxy mask a good bit.
Yeah. I just use those as trach now.
Yeah, exactly. Right, so what's one reason we use this? What did you just say?
Well, I use them for trachs, yeah.
Right, so trach transport, so if you have a trach and they need to go and transport, you hook it to a Venturi mask to the trach collar, and that's how they can transport. How do you know what FiO2 the patient on the Venturi mask is getting?
It says it on the card.
Right.
Very
It says it
hard
on
to
it.
read.
Color coded.
I can see me on my
It's exactly, it's on the
I know,
bottom.
I'm like.
You gotta feel the number like Braille. Okay.
I agree. You have to kind of get my reading glasses out, you know, have my bifocal contacts on and all that stuff, but it's a little hard to read, but it is on the bottom. And it's also, a paper comes in the bag also that tells you. But we'll pass around, the blue one's a little easier to read, so we'll pass that one around so you can make sure you see it. The cup that we put on here, you'll see it a lot of times without this cup. It is a good idea to put it on here. If not, if the blankets or something get wrapped around here.
I just wonder, I mean, I put it on this.
So what happens, do you think, if, now, the Venturi system works because it's in training room air, right?
Mhm.
And then the oxygen is coming through here. And depending on the size of the Venturi port, depends on how much room air is in training, and that's how much oxygen they're getting, right? So if you have somebody on this and like the blanket gets wrapped around here or something, what happens then?
They're
Exactly, exactly. So it's important how much oxygen they're getting, and we're worried about that. You know, we should just get in the habit of putting that on. You know, it's something we should do. The non-rebreather, everyone should know where to find a non-rebreather in your unit. Do you know where to find them? Where can we find non-rebreathers?
Now it's in the respiratory room, it used to be in the, in the cabinets, we don't have them anymore.
Some of them are in, they're occasionally in the cabinets.
Most of the time they'll say that there's a box, but it's actually the oxy mask in them, but there should be one or two in there. Where else can we find, in an emergency, where can we find a non-rebreather? Right, in the airway box there's one. But every unit should have non-rebreathers. You should check to make sure there are non-rebreathers on the unit. We don't want as many as before because we don't want them used as often as we were using them before. We can use the oxy mask or something that we can hydrate down instead of putting a patient on something where they're getting close to 100% oxygen and just leaving them on there. But for an emergency situation, a non-rebreather is, an essential tool that we have. So we already talked about it before, but what's one of the important things about the non-rebreather?
Yeah.
Make sure it's in the
Yeah.
Exactly. So you want to make sure the flow is high enough to keep the bag inflated on inhalation. Okay, because what happens if it's not?
Yeah.
Right, exactly. So can deliver between 60 and 90% FiO2. O2 liter flow should be adjusted to allow reservoir bag to partially collapse on inspiration, and insufficient O2 liter flow can cause CO2 retention. Any of the oxy mask, the Venturi mask, and this mask do not get humidity hooked to them. Okay, so that's one of the reasons why we talked about the aerosol mask and the humidity on the non-rebreather. So we're a little limited to our oxygen devices that we can hook humidity to. And you always want to be conscious of that. You want to make sure people aren't getting really dried out and that they have the proper humidity that they need. When do we bag a patient? What was that?
When they're not breathing. Or they might need a little help, maybe their respirators are really shallow, yeah, and they give a little assistance.
Right. Or if we go into a room and you walk into a room and the patient's completely different than they were before, they're really agonal breathing, you want the team to get there, but you're not quite sure. Whenever in doubt, reach for the bag and start bagging, right? So this bag comes like this, and you need to pull both sides out before you start ventilating the patient. We are going to be switching to new ambu bags soon. I should have brought one if I would have thought about it. But they're very nice. They have a little strap on here that you put your hand through. This is a PEEP valve. The PEEP valve is not automatically on these now. We have to get one, which are in the airway box too. We have to get one and put it on here. The new ones will have a PEEP valve automatically attached to them. The other nice thing about the new ones, what I was talking about earlier, is making sure that this is hooked to oxygen. Right now, this looks like any other oxygen device, right? So you could come into a room, see someone bag it, and just happen to look, and you'll see something hooked to the flow meter, and it's turned all the way out, so you think you're good. Well, we've had situations where it's the nasal cannula or something else hooked to the air. Our new ones actually have I want to say it's a red tip with green rating. Is that what it is?
It has a sticker on it.
Yeah, that says oxygen. So it'll have a different color tip with a sticker that says oxygen on it. So when you look up there and see, you're going to know that your ambu bag hooked to oxygen. It's very important. You might be saying, "No, that's goes without thinking," but when you're caught up in that moment, it just happens. So that's something you always want to make sure you see. So you know, all of you go through CPR training. You don't need to know how to do the mask, but these are some important things that we need to make sure that we remember about our ventilation. You don't have to, you know, do full big neck breaths or anything like that. You just want to do 1 to 1.5 liter is the capacity of this bag. So we don't give our patients 1 to 1.5 liter, right, when we're breathing for them. So you just need to do little breaths, and depending on the provider there, they may tell you to breathe a little faster or breathe a little slower depending on the patient's needs. But most of the time, it's about every 5 seconds or so you can breathe for a breath. Just remembering the PEEP valve, that's one of the things right now that is not on here, and sometimes they may ask for. Okay.
So explain the importance of the PEEP valve.
We're going to watch a video a little bit about it. Okay. So we'll look at that video and you'll see it. So what is mechanical ventilation? Mechanical ventilation is a procedure in which a device is used to administer positive or negative pressure to move air into and out of the patient's lungs. May assist or replace spontaneous respirations. There's 2 types, non-invasive and invasive. First of all, let's talk about something. So you go into a patient's room and the patient just doesn't look good, and they're telling you, they say, I can't breathe, I'm not breathing well, but you look at the sat monitor and they're satting 97%. And they're saying, that thing's wrong. That thing's just wrong because I can't breathe, and they really can't breathe. What's the problem? What kind of issue is it? Exactly, ventilation. So we always have to keep in mind we're dealing with 2 different things when it comes to the respiratory system, right? Either oxygenation or ventilation. And when we're talking about that, when we're looking at the patient, we want to think, well, what are we trying to fix? Are we trying to fix oxygenation or ventilation, or are we trying to fix a combination of the both? Because sometimes we are. So like with a COPD patient, a lot of times, which one would we be trying to fix, do you think?
Ventilation.
Probably ventilation.
Yeah.
So their oxygen with a COPD patient, their oxygenation is typically going to be low. We want their oxygenation to stay somewhere around like mid-80s to low 90s at most. And on a blood gas, their PO2 is probably going to be like 60, and their normal CO2 is probably going to be like 60. But if they're in exacerbation, they're going to come in and their CO2 could be greater than 100 or whatever. So we would have to deal with the ventilation problem. Not to say there's not times that we don't have to do oxygenation, because we certainly do for sure. But a lot of times it's a ventilation problem. So what will we use to help that patient? Who said it? Right, BiPap. So we could use a BiPap to help that type of patient. Then if there's a patient that comes in and they're breathing okay, it's a pneumonia patient, their stats are like, say, 83%, they just look pretty bad. What type of device could we use for them? Yeah, high flow, yeah, exactly. High flow nasal cannula. So my point of this conversation is that we have to kind of think, like, what are we treating and what device works best for this patient? We've definitely gotten away from using BiPap on pneumonia patients. we found that the benefit does not outweigh the risk, and it's much safer to put a patient on a high flow. So just always keep that in mind, that it's two different systems that we're working, well, one system with two different things that we're thinking about. So the goals of mechanical ventilation are to treat hypoxemia, treat acute respiratory acidosis, relief of respiratory distress, prevention of reversal atelectasis, resting of ventilatory muscles, decrease work of breathing, improve pulmonary gas exchange, and permit lung healing. So what are some things that you notice when you walk into a patient's room and they are in respiratory distress? What do they look like? They can be cyanide.
The muscles they use, they're just really, you can tell they're working hard.
Great accessory muscles used, yep, so you'll see all that kind of sinking in and abdominal breathing, belly breathing. They could be breathing faster. They get confused. They could definitely get confused, yeah. Anything else? How about tripod position? If you sit in the tripod position, how do they ever see on breathing? Personal breathing, all that stuff. They could be diaphoretic, you know, any of those things. They could be a little bit more, you know, grumpy. They could be getting a little grumpy with you. You know, any of those things could be happening. So, what's considered non-invasive ventilation? BiPAP, yep, BiPAP, CPAP. Indications: obstructive sleep apnea. Which machine do we use for sleep apnea? CPAP, yep. COPD with exacerbation, neuromuscular disorder, acute lung injury, and in some cases weaning from the ventilator. Patients we would not want to use it on are respiratory arrest, uncooperative patients, inability to protect their airway, trauma or burns to the face, facial, esophageal, or gastric surgery, poor respiratory drive, reduced consciousness, and newborns. So why would we not want to use a BiPAP on someone with reduced consciousness, or someone that has like an inability to protect their airway? What would we want to do? Right, intubate the patient. So with BiPAP, you always want to use it on somebody that, for the most part, can protect their airway. Someone that is, what's another thing that you wouldn't want? Someone that's not vomiting, right? Someone that's not vomiting. Someone that, for the most part, you don't want to use as a ventilator, right? So BiPAP and CPAP, mask maintains a seal, but the seal is not going to be pushed down on the face super hard or anything. Acute or maintenance therapy. We have some patients that come in that have been on BiPAP at home, you know, all the time, or CPAP at home. CPAP only initiated and administered with a provider order. That's for anything, of course. Bilevel positive airway pressure provides both inspiratory and expiratory support. There's an IPAP pressure and an EPAP, which is CPAP. Okay? And we're going to turn the machines on in a little bit and go through all this in a little bit more detail. Titer is not better, and mask is designed to leak. We check on Monday, Wednesdays, and Fridays. The resource therapists go around and check each patient that's on high flow and BiPAP for skin, to check the skin. We check to make sure that there's no breakdown on the nose, on the cheeks, and behind the ears are the main places we look. We have things we can do to prevent sores, and you do not want to tape over anything on the mask, for the BiPAP mask. On the BiPAP, we have several different masks. You know what this one's used most often for? CPAP, right? Yeah. But it can be used for BiPAP if the pressures aren't too high. Like, there's nothing in stone, but like I'd say nothing higher than about 12 is usually where you wouldn't want to use this. This is the mask you typically see. And what are the problems you have with this mask? Do patients ever rip it off, or is it hard to wear off? Or
Always.
yeah. It can adjust up here too to try to keep the pressure off the nose. You can adjust it so that it's putting a little bit more pressure on the forehead to keep it off the nose, but there should be nowhere there's a ton of pressure. The clips you should just be able to roll right off with your thumb and then pop back down. Okay? to keep it, because
It's always like in their mouth.
In their mouth,
when I
the
see
bottom
that.
thing.
Yeah.
then it may not be proper fit,
Okay.
or it just has to be adjusted. This is the same, this mask will be used for the same thing, it's just a different type of mask. This mask is a little better for patients with sensitive skin. This one just sits really on top of the skin, and you should actually see it rock a little bit when used with each breath. The top does not touch the forehead at all. The nice thing about this one too is there's little places if they have a OG or something like that which come out, because with that mask a lot of times it causes a leak, so that you can just kind of put right through here. So just remember with this mask, it does not have to be down, you just kind of rest on the face. Okay? And then this mask we do not use very often at all, but this actually, believe it or not, is good for people with claustrophobia or any kind of facial trauma that we're going to still use the BiPAP on. It covers the whole face, and the reason they say it's good for claustrophobia is because when you have a mask, that mask kind of goes like this, and it blocks the vision, so you really can't see it, you know, see well through it, and you can see that there's something there. With this one, you have clear vision. So that's sometimes why we use this one, or sometimes if we just cannot get a good fit with the other ones, we'll try this one. Okay. I never really thought about how much the mask blocks the vision until recently. We had a patient who ended up, who had been on a non-invasive ventilation, and he ended up being trached. One of the things when I asked him, I said, you know, because it was a big decision if he was going to be trached or not. When I asked him, you know, are you okay with your decision? He said yes, because I could kiss my wife, I could tell her I love her, and I could see her clearly without the mask in the way. And that just, I thought that was the sweetest thing in the world. But I never really thought about, I've thought about like not being able to eat, not being able to talk, and I've thought about like families, you know, to interact with their patients, but when he said all those things, it just put it in a totally different perspective to me. The high flow, we have two high flow systems now. The high flow is a heated oxygen delivery. We can use it through the nose or through a trach. Flow and oxygen are adjusted by respiratory to achieve targeted sats, normally greater than 90 or 88 to 90 depending on the order. The temperature is set at approximately 37 degrees Celsius to start. We can change the temperature if the patient says that it's too warm, but the heater must always be turned on. So that's one thing to be conscious of. If you're taking a patient off high flow, want to put them back on the high flow, you have to make sure that that the heater is on to a proper temperature. The water bag should never run dry, so if you ever see the water bag like really close to dry or dry, you need to let us know right away because it's really bad for the patient. Sometimes there gets water in the tubing and we have to dump that, and I'll show you when we're looking at the machine. Again, we want to look for sores in the face and the ears. This is no longer the case, so if we have a patient on a high flow or a BiPAP and they need to be transported, what should we do? What's that? Right, okay, so you call respiratory, and then what I'll say, you think they can come off the BiPAP? Can we just take them off and put them on whatever we want? We need to get an order or talk to the provider and find out what they would like them on, right? So now we can transport, of course, on our BiPAP. Prior to recently, we were not able to transport on high flow, so we had to switch to a different device. We still have those high flows in service, so if the patient is on that, we can either talk to the provider and see if it's okay to switch to a different device, or we can switch out to one of our high flows that we can transport on. So now we have plenty of high flow devices that we can transport on, so that shouldn't be an issue. Okay. When you're looking at the device, you may see some adjustments in the variation in the oxygen. If the patient's nose gets a little occluded or the prongs move a little bit, it's going to adjust a little bit up and down, but it shouldn't be a wide adjustment. It shouldn't go from 40 to 70 or anything like that, but it may not be exactly a $40 time.
One thing I just forgot to mention at the beginning, I will email the slides out to all of you. So I see some of you taking pictures. I'll email them out so you guys will have them to print them. Okay, just so you know.
That's nice.
So you can say if you're like writing aggressively. I'm sorry, I should have meant to say that in the beginning. Sorry. You're welcome, Steph.
And we're always around, so you can always ask us a question too. The ET2 provides patent airway, access for suctioning, needs of mechanical ventilation, and protect the airway. So when you look at this ET2, what are the things that you notice? What are some things you need to be mindful of on the ET2?
The number that is on wall.
Right, so you want to look to see where it is at the lip, right? And when if you're moving a patient around, say you're changing the sheets or cleaning the patient or just lifting them to bed or whatever, you always want to be mindful of where the patient is. Like say they're 24 at the lip, you want to make sure when we're finished they're still 24 at the lip. What is this? Subglottic suction. So we hook this to low continuous suction. And what is the reason for it? Right, keep secretions, and it's to prevent that, which we have been that free for over a year. Woo! So that's very exciting. That's very exciting, and it's a lot of work that goes into that. So everything that we do to help with that, you know, is a good thing. And then this is for the cuff, right? So this is just to do cuff pressure. Be very mindful, like if you hear a leak, don't just grab a syringe and start putting air in it. And when we bring out our little guy, our trach guy, I'll show you some reasons why we don't want to do that, okay? We have manometers that we can put on here and actually read the cuff pressure. And that's what we do at least twice a day. Each shift does it at least one time a day, okay?
Can I just say, sometimes if you hear a leak, it's most likely the subglottic. So if you pinch that off and you don't hear a leak, then it's the subglottic making you feel like the patient has a leak.
Has anyone ever seen an LMA?
Yes.
Yeah? When did you see it?
For a code situation when you can't intubate your patient right away.
Exactly. Sometimes they'll come into the ER. That's where we mostly see them. It's very rare that we'll use it here as a means of intubation. When they come into the ER, they may have this, and then when it's safe, then we'll secure a different airway. But the tube is advanced until the mass settles over the esophagus and larynx, used for short-term ventilation when intubation is not possible. Cuff pressure should be approximately 60. So basically, you can ventilate with this. It gives a safe airway so that you don't have to mass bag ventilation anymore. And it does work. It definitely works, and it's much easier than trying to keep fighting to get an ET tube in if you just can't. Okay? They're no longer in the airway. They are.
No, they're not.
Yeah,
The
they're
airway
no longer
boxes.
in the airway boxes.
They're in CCW and ED, and then
They,
operative areas use them routinely.
Difficult
They should be in the
airway
difficult area.
part.
Mhm.
Okay.
Yeah, and it's always good to know where they are because it's never a good day when you're going to get one of those. You're never like, you know, where's the LMA? You know, it's like, somebody get the LMA, you know? So it's good to know, kind of like a non-rebreather, exactly where it is so you're not running around.
Something else is good to know where they are is, what is this? Bougie, tube exchanger. So if you're in a room and someone's yelling, that's going to be the same thing. They're not using once in a while because we're just changing the tube out before a preventative reason, like maybe we think there's a cup leak or something like that, we'll change a tube out. But a lot of times if you're changing a tube out or somebody wants a bougie, it's for an emergent reason. They are in the airway boxes, in every airway box now, okay? So then there's also some in the unit,
The
in
respiratory
our
room.
room. But they're in every airway box. So if somebody yells they need a bougie or a tube exchanger, this is what they're talking about.
We also have an oxygenating introducer as well in our respiratory room that looks a little bit different than that. I think it's white.
It's
Looks
like
a little bit
metal hole with a little white cap on the
Yeah.
end that goes inside the bougie.
Yeah.
And you can bag through it.
Do you guys know why we use the tube exchanger or the bougie? So it's, if you have an airway in, say like in the ER for whatever reason, they couldn't get a tube in, so they had to put a really small airway in, then when they come up to the unit, they need a bronchodilation or something like that. They don't want to leave the really small airway in. So they will put the tube exchanger down the existing ET tube, leave it there, pull the old ET tube out and put the new one in over top of the tube exchanger. And that way it helps give them the path to go where they need to go. Okay? Does that make sense? Trachs. Surgical airways created to bypass the upper airway, allow removal of secretions, prevent long-term ventilation, prevent aspiration of secretions, and replace ET tubes. So what type of patients have you seen that have been trached?
Patients that can't come up to vent, they can't be laid off.
ALS is a very difficult disease, and progressively they're going to get worse, and if they choose to continue, they'll end up trached normally. And we'll talk about the different modes of ventilation for patients with neuromuscular disorders. So, do you all have any issue with any trach patients? Have any of them just pulled the trach out just because they like to?
Oh, no, that's happened a few times.
Yeah, especially when they get up to 4 West, they like to do that.
We can move faster than we have to.
Yeah. So sometimes there are patients that like to just pull it out. I think they like to have people come in the room occasionally, or there are people that are confused and pull it out accidentally, or things like that. The trach can become occluded. So what would happen if you went to a patient's room and they just weren't breathing well? What's the first thing you would do? They're not on a ventilator. They're just on a trach collar. They're not breathing well. Their stats dropping a little bit. What's the very first thing?
Suction.
Suction.
Okay, you can try to suction. Okay, you can't pass the suction catheter.
You can pull the inner cannula out.
Good. Yeah. So you pull the inner cannula out. You pull the inner cannula out. Oh God, it's hard to. And there's a big plug there. So what's the great part about having the inner cannula? You pull this big plug out.
Get rid of it.
Right. So there's still a patent airway here, where you can, the patient can still breathe fine. You pull the inner cannula out and replace it with a new one, we're good to go, right? So that's something to always keep in mind. You always want to make sure that there's an inner cannula in the patient and that it's the right size. That's important too. Respiratory does trach care once a shift, so twice a day. We change the inner cannula, we clean around the site if we need to. We'll change the dressing. So this is what we'll use when it's just a patient that has normal secretions, that there's no problem, as long as they're not seizures.
Is there a case where you have to pull out the inner cannula and then you're still plugged?
Yeah, so then we would either try to maybe lavage and suction that bronch if we could quickly, or if not, we have to exchange the whole trach. And we can do that emergently. Right.
And then you exchange, so therefore, when you do the emergent, does the doctor have to be there, then just the
It
respiratory?
depends. It depends. Respiratory can change trachs after they're established. If it was emergent situation like that, I would definitely be calling a provider on the phone to have them come, but we could certainly do it in the meantime. Anytime there's a situation, like a couple months ago, I was going to do just a routine trach change for someone that had had a trach for quite a while, and I was in 2 North, and the patient had, I think it was say maybe like March or April, something like that, and the patient had on their trach said December or 12 or something like that, and they said that they had changed it in December. Well, when I went to pull the trach out, like I couldn't get it out. Like I felt like I could not pull this trach out. So I called one of the CCW providers and asked them to come. He came, he's like, oh, it's an established trach, it shouldn't be an issue. And he came, he started pulling, he's like, this is not going to be easy to get out. Well, the patient's trach, so when patients have a trach, it should be, the whole thing should be changed about every 30 days. So when the patient's trach, we do a first trach change within a week, and then a week to 10 days or so. then trach should be changed every 30 to 60 days. When patients got in the community, that doesn't always happen. So with this particular patient, what we think happened was, it was December of the previous year, and scar tissue had started to adhere around the trach. When we pulled the trach out, it was actually like hard plastic. So we had no problem getting it back in, but you know, I didn't want to take that chance. So respiratory therapist is never going to take a chance if we think that we could cause harm to a patient. But in emergent situation, we would definitely do what we need to do to get it out and clear that obstruction. So what happens if you can't get the trach back in? What are you going to do?
Smaller size.
You're just in the room by yourself.
Oh.
You're in the room by yourself, the trach came out, the patient's starting to desat, you can't get the trach back in, what are you going to do? Where are you going to bag? Everybody's saying different things, say something. Okay, where are you going to bag?
Or the hole for the trach is, if I can. If
Okay.
it's plugged, then no.
Okay. Does everyone agree with that?
Yeah.
When can you not do that? When can you not bag in the upper airway? Right, laryngectomy patient. So always be mindful. But a lot of laryngectomy patients won't have trachs, they'll have stomas or Larry tubes or something like that. But always keep that in mind. If you have a patient that has some sort of trach, stoma, anything like that, you always want to make sure they're not a laryngectomy patient. We'll go over our signs that we have in the rooms. So we should have a sign above the bed, but just make sure you're aware of that. But right, so you could either bag through the stoma or cover it with some gauze, whatever you have handy, and then bag through the upper airway. Yep, exactly. Okay. So this is what we're going to use for a patient that has just, you know, your average secretions, and then the polymem is what we're going to use now for patients with excessive secretions. Again, we always want to make sure we're protecting skin, so we do whatever we need to do to make sure there's not breakdown around the trach as well. If you see a patient that has sutures for more than a few days, we should be tracking that and making sure we're removing the sutures, but just let us know and say, hey, you know, this patient still has sutures. A lot of times they're not putting sutures in anymore, but still they do sometimes, and we should be tracking also that first trach change within the first week. A lot of times the first trach will be a size 8, and then we'll try to change it to a smaller size right away if we can. What's the benefit of if the patient's not going to be on the ventilator, especially of downsizing the trach to a smaller size?
Different communication.
Yeah, that's good. It can be for communication, it can be to help them breathe around the trach, right? Because if they have this in their, most times they're not gonna, we're gonna switch it out so it doesn't have the cuff on it too as well. But we wanna give them as much air around the trach as we can to start weaning them off, right? We've all pretty much done trach care here, right? We're taking this inner cannula out. So when you put it back in, you just wanna make sure you hear the click. This is a Portex trach. The other trachs that we have in our facility are XLT Shileys. So this is used for like an average size patient. Some of our patients aren't quite average size and have really big, thick necks. So we would use Shiley XLT. Okay, we have some that are longer this way and some that are longer this way, depending on what the patient would need. And this, the inner cannula just comes out a little bit different. On the Shiley, you can look right here and see the size. On the Portex, it's on here too, but it's very hard to read. If they have a cuff, it's on the cuff and it's much easier to read. One thing I want to mention, so I don't know if any of you were at, I think, were you guys at the in-service that Passenger did? Were you there? Yeah. So Passenger came and did a pretty good in-service about speaking valves and that sort of thing. So when should the cup be inflated? Inflated. When should the cup be inflated? Right, when they're on the vent. So if our little guy here doesn't stay in place very well. But if we have air in the cup, and then we keep on putting air in the cup. Now keep in mind that they're, you know, it's in their airway, and we just keep adding air. What can we do? Right, so we can cause damage by keep adding air, right? The other thing that I know I'm guilty of, and I've never thought about before, they were telling us, how many times have you gone into a room and said, oh, there's a leak, let me check this, and you start hitting on this, start touching the balloon and feeling it? It actually, it's a little bit hard to see, maybe if I take a little bit of air out, or we can pass this around. See, it actually causes the cuff to come in and out, and actually can cause damage too. I've probably done it hundreds of times, to be honest with you, never really thinking about it. So you want to be mindful of not going in and keep going, how do you say, let's see, is there air in this cuff? Is there, because you really can cause damage by doing that as well. So we want to use our proper tools to test for proper pressure in the cuff, okay? Does that help to see a visual of the cuff and how it kind of can cause trauma?
Why is it so important for a nurse to know if their patient's trach is cuffed or cuffless? Why does that matter to you? I mean, speaking valve, yes, it's important for speaking valve, but something that's more important than that. Why would you want to know? If you think about it. Unrelated to speaking valve. Dislodgement or decompensation. So we just talked about how any patient who's on a ventilator, right, is going to have their trach, what? Inflated, deflated? Inflated always. Okay, so that's simple, right? So that's always going to be the case. But for your patient on trach collar, how would you know? What's your tip off to know if the nurse in report didn't tell you? If it's inflated or not, or if it's cuffed or not? What would you look for? The pilot balloon. Yeah. Okay, so you have your patient, let's say you get called to a code on 4 West, it's not your patient, you're on the code team, and you walk into a room, patient's completely unresponsive, and you have to start bagging them and they have a trach. You would need to know why.
Because
if it is a cuffless trach, what's your problem now? You cannot use the ambu bag with their trach. So what would you do in that scenario? It's just you and the other nurse is doing CPR.
Cover the trach and bag.
Yes, exactly. So it's good to kind of think through that, because ideally then, you know, when respiratory arrives, yes, eventually can we get the trach changed out to a cuffed? Yes, hopefully. But in emergency situations, you need to know if it's cuffed or cuffless, because it would be a very different scenario if it was a cuffed trach and it was just deflated. You could simply inflate it, you know? So you always need to know that when you're getting a report from the ER, if a patient's coming up with a trach, you need to know if it's cuffed or if it's cuffless, because if that patient decompensates, your plan of action is going to be different based on that. You know, so that's really important for you to know. It's important for you to always be giving that in handoff, and if it's not mentioned, you need to ask the question, and if not, you need to immediately go into the room when you're doing bedside handoff and ensure that the other nurse understands why that's important. Because in critical care, we're going to have cuffed trachs more often because they're new and patients go on vents, and so. But when we get admissions from the ER, like patients who are out in the community, a lot of them have cuffless trachs. So it's all well and good until they decompensate. Okay, so as critical care nurses, as part of the code team, we have to know that information. And for anybody on 4 West, same thing.
Because we don't.
Same thing.
We don't say that in report.
You have to know that. You have to know that. Yeah, because you could be bagging somebody, and it's the person you least expect, right? To decompensate, because they probably have a speaking valve on, and they're talking to you, and then they're not, and then you have to know what to do in that situation, because if you start bagging them, they have a cuffless trach. You're not doing anything, So I think that's something that maybe isn't stressed enough.
Right.
Yeah. So I think that's really important to know.
Dumb question, but you said look at the little blue to know if it's cuffed or uncuffed, inflated or deflated. So if it's deflated, that blue will be full?
It will be flat. So if it's deflated, that balloon will be flat.
But even
And
just
if it's
looking for the
inflated,
presence
so-
of a pilot balloon, there will
just
be no
looking.
pilot balloon if it's cuffless. So that's an easy tip off. Just make sure you're not confusing like subglottic, that
So
you
this
know you're
one,
looking at.
this isn't a vortex, it's a Shiley, but there's no pilot balloon, so there's nothing here. There's nothing hanging off, there's no tubes hanging off. This is a cuffless trach.
How much do you inflate a trach with if it's a cupped trach but it's not inflated? How much would you, 10 cc's, how do you know how much?
If it's not inflatable, we would
Yeah.
use our capnometer to measure pressure.
But if it's only you and you're trying to bag the
Yeah,
patient?
you could do like
Whatever you want.
8 cc's or,
Okay.
yeah, just
Yeah.
get it inflated and start that. So,
Yeah.
on, any trach patient should have this sign above their bed, and this sign should tell you the date the trach was performed, the size trach, the size suction catheter, and the 2 sizes at bedside. Why do we keep 2 sizes at bedside?
Same size, same size smaller.
Right.
So the same size won't go back in.
Exactly, exactly. Did everyone get that? Same size, size smaller, in case the same size is harder to get in. And we also say the suction catheter size. Why do we say that? You know why that's important? So if somebody has like a size 6 trach, then we need smaller suction catheters.
Right, you can't get
So
lower down.
I try to think in my head, and this isn't like an official thing, but if they have a 6, then they need a 12. If they have a 7, a 14. So I just double it, and it's not official, but if they have a 6, the 14 is too big for their trach. Okay? On the back of these little cards, if you ever get a chance, you should look over this. In an emergency, it's going to be hard to take this off the wall and look at it and read it. But if you're prepared ahead of time, the more prepared you are ahead of time of an emergency, then the better off you're going to be, right? The more you go over scenarios in your head, the more you think, okay, if this happens, this is what my next step is going to be. If this happens, I know that this supply is in this place. So the more you prepare yourself before the emergency, the better you're going to be. So if you ever get a chance to look at the back of these signs, there's this little algorithm, and it kind of walks you through scenarios. The same is for our laryngectomy patients. So again, what did we say about laryngectomy patients?
Can't.
Right, exactly. So these signs should be in that room, and there's the same thing back here too. Okay? There is a, what's it called, neck breather.
A flag and epic.
Flag, put in Epic.
FYI banner.
It really is not intended for trachs, it's intended for laryngectomy patients, but I think we've used it for everybody. But the intention of it was really for laryngectomy patients, but I think it just goes in for anybody. It has a kind of an airway, a surgical airway at this point. So just keep that in mind also. Okay?
They're hanging above the beds when we fill them out, those signs, and they're also hanging off the crash cards, the algorithm,
Right.
if you want to look at it.
So we kind of talked about the brands that we have. We have Cortex and Shiley, cuffed and uncuffed, standard length and extra long. We don't really use Fenestrate too much here. Fenestrate has a hole that provides for speaking a little bit better. Single cannula and disposable, so that is something important to know. The trachs that we have here are all disposable intercannulas, but someone could come from the community that has an intercannula that is not disposable. So at that point, what do we have to do?
Clean it.
Yeah.
Go back.
Yeah, so we have the little trach care kits that we use to clean it. A lot of times in that situation, the patient likes to take care of their own stuff, or their family likes to take care of it, and that's okay as long as we make sure that it's being done properly. The suction aid, which allows the clinician to remove pooled subglottic secretions. About the cup, we talked about that a little bit. So we do, when we do our vent checks or whatever it is that we're doing every 4 hours, we check to make sure that subglottic isn't occluded or blocked in any way. But you'll see us with a syringe sometimes pulling on that. It's not to remove secretions, it's just to make sure that it's still flowing and there's no occlusion in it. We talked about our sign. If you don't see a sign above a bed, please let us know.
Those signs only come from respiratory.
Yes. So, the cuff should never be inflated when a speaking valve is attached. Trach ties must be secured with no more than 1 to 2 fingers in between. So think about that, like if a patient coughs real big or something like that and it's not secured, that trach could pop right out. Notify rapid response, respiratory, or provider immediately if you have difficulty passing a suction catheter. We talked about the layers.
Let's go back. So if it's inflated and you're trying to speak, just it creates more pressure Like, what's the rationale? Like, what's the rationale?
Okay, so if you put a speaking valve on this patient and you inflate the cup, Paula, there's a speaking valve in that black box. So the speaking valve basically, yeah, it's right here, right? We put it on here. So in order, and here's your speaking valve. Okay. So to put the speaking valve on, you just softly turn it on. You don't have to push real hard or anything. So how does the speaking valve work? Do they want to know? Right, exactly. Did you hear? It's a one-way valve. The air comes out, and you're able to speak. You know, the air needs to be able to come in and out around the trach. If the cup is inflated, what happens?
There's no air moving.
Right. Okay. Does that make sense?
Yeah.
So it's almost like plugging the trach to some degree. So when you put a speaking valve, that's kind of the way you have to consider it, is that you're basically plugging the trach.
But if the cuff's inflated, you're like suffocating them.
Right. They won't be able to breathe. As soon as they put it on, they'll start going. If the speaking valve gets dirty with like a lot of secretions or something, you can rinse it with water and soap or just water, shake it out real good, and then you put it back on the patient. It doesn't have to dry. It can go immediately back on the patient. Okay. There are patients that are on the ventilator. A lot of times it'll be a patient that's on a home ventilator where we intentionally leave a leak. Why would we intentionally leave a leak? You know? So they can talk. So they can talk around the cuff, so they can communicate. Some patients on a home ventilator will actually eat, and when it's a patient like that, we'll leave it slightly deflated too, because they can talk, they can tell us what's going on, that sort of thing. But there are like long-term ventilators that are on, you know, at home. So invasive ventilation. Respiratory failure, indications. Respiratory failure, airway compromise, cardiac arrest, trauma, head, neck, chest, tumors, infection, strokes, overdoses, tumors. We have all kind of reasons. Basically, if the patient can't maintain their airway, if they're not breathing, then we would have to intubate them. From a nursing perspective, you're getting ready to intubate a patient. What do you have to do? Julie, this is going to be your...
They know.
So what do you have to do? They say, we're intubating
People
this
know.
patient.
Make sure respiratory has.
Call respiratory.
We're there.
Good answer.
No.
What medications do you give?
Depends on the doctor.
Okay.
What 2 classes of medications do you need though?
Paralytics.
Which one do you give first? If you're nice.
Yeah.
Sedation first. Very good. It's good to have restraints. The glide scope, our little McGrath. You guys know that.
Supplies needed. The red airway box, which includes ET tubes, many sizes, blades, all that. We're going to go through the airway box. The bag hooked to oxygen. Good. Medications to include sedation and paralyzing agent, the McGrath or whatever video scope they're going to use, suction, and a stethoscope. Kind of, if you're in a room and there's an intubation and then we look around the room and say, does anyone have a stethoscope?
Happens.
Yeah, it's happened before, so we want to make sure there's a stethoscope. What are the different ways that we can confirm ET tube placement? So end title, that's absolutely, we definitely need end title, and we prefer graphing end title. We do still have the color changers, but we prefer graphing end title. What else? Breath sounds. And chest x-rays, right. Right. I'm gonna take a 5-10 minute stretch. Are you good? Everyone good for right now? Okay. All right, we'll keep going until we do the machines done. Okay. So some different terminology. The tidal volume. Tidal volume is basically how much air you're taking in, right? Every time you take a breath, you're taking in a certain amount of volume. So the volume of gas, either inhaled or exhaled during a breath. The respiratory rate, how many breaths per minute? FiO2 is the oxygen delivered. The minute ventilation, the average volume of gas entering or leaving the lungs per minute. The peak inspiratory pressure, pressure needed to deliver set tidal volume. So why do we care what the pressure is? Should we care if the pressure goes up to 60?
Yes.
Why?
Well, something caused it to do. So maybe there's a kink in the tubing.
There could be a kink in the tubing.
One of the patient's respiratory status is declining.
Okay. What else can cause the peak inspiratory pressure to go up? They could be biting the tube, secretions. They could just be anxious. They could be, and we'll go a little bit more. Positive end expiratory pressure, peak. The amount of positive pressure that is maintained at end expiration. The purpose of peak is to increase end expiratory lung volume and reduce airspace closure at the end of expiration. So we're going to go over that a little bit more in a few minutes and show a video that's pretty cool. Event is event is event. So we have just 2 different ventilators in our facility. The ventilator itself may look different, but most ventilators have the same modes and respiratory waves. If there's something wrong, when in doubt, what do you always do? Guide the patient, right? And respiratory should always be available. So we have the servo I, which is in use for any patient that's staying on the ventilator, and then we also have the LTV, which most of you have seen, I'm sure, and that's our transport ventilator, or the ventilator that we put on patients in the ER usually. But we can put them on either one. A lot of times we'll put them on the ER because that way we can put them on the LTV, we can do CAT scan, MRI, wherever we need to go, and then we can transport them up to the unit and then place them on the servo I. We can also transport on the servo I. It's just not quite as user-friendly when you're transporting through the hospital. So modes of invasive ventilation. APRV is airway pressure release ventilation. We go over these, so I'm just saying these. Volume control, assist control, pressure control. PRVC is pressure regulated volume control, and CPAP pressure support, which is continuous positive airway pressure. Which modes do you guys see usually? Volume control, pressure support. Yep, exactly. So ventilator modes. Bivent we really do not use that often anymore, but a bivent would be used for a patient that we really need to increase the oxygenation. So a patient with poor oxygenation, like an ARDS patient or something like that. Apply CPAP, pressure high, for a prolonged time, and the time is the T high, to maintain adequate lung volume and alveolar recruitment, used to improve pulmonary gas exchange by opening collapsed alveoli. Applies a time cycle release phase to a lower set of pressure for a short period of time, where most ventilation and CO2 removal occurs. So that to me sounds very confusing when you say that. Basically, the sum of bivent is, it's a reverse ID ratio. So when you breathe in and out, you really usually breathe in for like 1 second and out for 2 seconds. So if you look at the machine, it looks like it's reversed, like 4 seconds to 1 second, or 6 seconds to 1 second, or even more. But that doesn't mean the patient is breathing in for those 6 seconds. They're not like, that wouldn't work. So what happens is they are delivered the breath, and then that breath is held. So the breath is held for extended period of time, and then it's released, and then it starts right over again. So basically, it's meant to help hold the bottom of the lungs open for recruitment. Okay, and it should be a spontaneous breathing patient, and it's commonly used for ARDS and acute lung injury. Can you think of any better way to explain that, Paula? I mean, when we turn the ventilator on, I'll show that mode, and sometimes when you see the waveforms, it looks a little bit, it's easier to understand, but that's basically the sum of how it works. volume control, which is the mode that we use most often. Inspiration ends when a preset tidal volume is delivered regardless of pressure. So basically, if we set a tidal volume of 400, that patient is going to get a tidal volume of 400 regardless of if it takes a pressure of 12, pressure of 20, or a pressure of 40. That patient is going to get that tidal volume. Each patient generates a respiratory effort over and above the set or delivered at the set tidal volume and flow rate. So it assists to decrease the work of breathing in patients with high minute ventilation and non-bleeding mode. So the benefit of that is we know that that patient is going to get that tidal volume every breath. It's not going to be a variable. But we want to, but something we would want to be mindful. What's that?
Don't they fight it a lot more than
It depends. You want to make sure they usually have some form of sedation. So what was it that I keep talking about with the pressure, right? So if their pressures are going up, we need to find out why and address that, okay? Because the volume is still going to be delivered, so we want to make sure the peak pressures aren't just climbing.
Where do you see the peak pressures on that? If you go back to that screen.
So right here.
Oh, okay.
And we kind of will go over that a little bit, so. Yeah. Pressure control, we don't use a whole lot. Inspiration ends when a preset pressure is reached, regardless of the volume delivered. So basically, it has a set pressure instead of a set tidal volume. And once, so you see the pressure is 20, the peak is 5, so those get added together. So once the peak pressure hits 25, the breath is over. So it's going to be a very variable tidal volume. So this breath happens to be a tidal volume of 514, but the next breath, once it gets to a peak pressure of 25, the tidal volume could be 300. The next breath after that, the tidal volume could be 700, okay, because we just don't know. It's going to be variable on the pressure. So it's used to limit peak pressures and improve oxygenation in patients with non-compliant lungs, allows the volume to change in response to intrathoracic pressure, limit the critical care and ED, and this is not a bleeding mode. Okay.
Why would they choose this over volume control? And what kind of patients?
So we have someone that's like super high pressures and you just can't control them and you don't want them hitting that thing. What kind of pressure, what kind of patient do you think would have those lungs or the airway? That is just super tight, that the pressures are going super high, the pressures are going way up? Was that asthma? We could use it for an asthma patient, yeah. Emphysema, possibly. So it's just patient, depending upon the patient.
And provider.
Yes.
I feel like some providers just prefer that.
It just depends.
It's frequently used in babies too. That's what, if we have a newborn that we have to vent here, we will put them on pressure control.
And that's because we do not run harm their lungs, which are much easier to harm than an adult.
Yeah, because you were them taking 450 tidal volume.
Yeah, exactly. PRVC used to be our go-to mode. It's not anymore. The providers just prefer volume control, and and it really is a combination of the different modes. So a controlled mode of ventilation, which combines pressure and volume control ventilation. A preset tidal volume is delivered at a set rate, but is delivered with lowest possible pressure. So it combines the advantages of pressure and volume control while eliminating the disadvantages. So basically you set the volume and then you also set an alarm at a pressure, and it's going to deliver that tidal volume, but when it gets to that pressure, the alarm's going to go off and it's going to say this is it. Okay, so we used to use that a lot, but the problem is the tidal volume can be variable with that also, because if they're hitting those high pressures, then they're not going to be getting the volumes. So most of the providers prefer that they get those volumes and that we just keep an eye on the pressures and control that through different means. Pressure support. Why do we use pressure support?
We
Spontaneous breathing support by a preset pressure. Patient breathing spontaneously and not tolerating other modes. Patients should not be sedated in this mode. Patients must have an intact respiratory drive. So what are some things that, from a nursing perspective, before we go and say, okay, we're going to flip this person over to pressure support, should you guys look at?
Other lung sound, if they sound better,
Okay.
and have them sitting all the way up in the chair.
They can be up in the chair or sitting up in the bed, yeah, how awake they are.
Probably hold off on Precedex and other, well, maybe not Precedex, because it doesn't sedate you, but maybe like their pain pills.
We want to, right, so any kind of sedation, anything that could slow down or knock out respiratory drive, we want to be mindful of that. If they're on like propofol or something like that, you know, can we turn it off or even, you know, turn it down or even turn it off? You know, so all those sort of things. On, how many of you work night shift? So on night shift, and this is kind of work in progress. So night shift, the therapist should be going in and checking to see if the patient is able to be weaned. There should be a discussion with the nurse about it, and then it should be relayed to the provider. If the patient's able to be weaned, day shift should come in. We should put the patient on pressure support, and then after a certain amount of time, we should be communicating with the provider to see if we're going to extubate or not. It should be a little quicker process than what's happening right now. So there's a group that's working together to try to get this process to work a little more efficiently. But it definitely needs to be a lot of communication between respiratory nursing and the providers. There's a group that is, those three groups working together to try to figure out how we can better communicate and document and get this process working a little faster, basically. In the morning when we come in, we do a RSVI to shallow breathing trial to make sure the patient qualifies from our standpoint, and then we put them on pressure support. If we flip them to pressure support and they just are not doing well, then we flip them back, or if they're doing well, then we leave them on. What are some indications you think, other than that, why would we not want to put someone on pressure support?
If they stop breathing, like, you won't know.
Right, well, we have the alarms.
Very good.
The respiratory.
Yeah, the respiratory.
Respiratory drive is down
So if they're on like pressors, we are hesitant to put them on spontaneous breathing trial, although some of the doctors will say go ahead and do it, just dependent upon the patient. So we always want to check with the provider. If they're on greater than 50% FiO2, if their PEEP's greater than 8, if depending on how much sedation it's taking to keep them in a comfortable state, they're all the things that we look at. And then before extubation, we would look at if they're able to continue breathing on the ventilator, if they can lift their head, if they can respond properly. Okay. So this is the video that we talked about that shows PEEP. This video will show us bagging without PEEP and bagging with PEEP, and you'll see the difference of how important PEEP is.
Okay, now we're going to hook the pig lungs up to a ventilator, a mechanical ventilator, and we're going to demonstrate a couple of things, basic respiration with the ventilator, and then what positive end expiratory pressure does, or we call it PEEP. And then we're going to turn the PEEP up so you can see the difference it makes for different types of patients that we would use it for.
So that black is atelectasis.
So you can see the ventilation.
So watch
much
those
more
black
effective
streaks.
when we're on the ventilator. I have this set up with a pressure setting. So our pressure is at 30 centimeters of water pressure, and then we currently have a PEEP set at 3, which would be fine depending on what diagnosis that your patient has. But for those patients who need a lot of PEEP, somebody who has refractory
You notice that the lungs are just kind of going right back down after ventilating.
ARDS, we have to use a lot of PEEP, and so we end up increasing that PEEP in order to increase the oxygenation, which works really well for alveolar recruitment and rebound or refractory hypoxemia. But we work so hard, if you can see us increase the PEEP, how much more inflated the lungs become and end up staying, because we keep that baseline at a higher level. And so we'll just keep increasing the PEEP. I've got it up to 8 now. And I'm going to add in here for the nursing students, we're not as savvy with ventilator lingo and what
things like PEEP are, but if you'll note, what PEEP basically is the pressure that the ventilator is going to leave in the lungs, so we don't have alveolar collapse and lose all of that headway that we've made with mechanical ventilation. So basically, in a nutshell, that's what PEEP helps us to do.
On the left side?
Up right here, you can see some of this area that's been collapsed. This whole video, you can see that alveolar recruitment. All those little air sacs are starting to pop open with every breath. And that's the point, because if they're not filling with air, then they're not carrying that oxygen to the blood to be carried to the rest of the body. So,
see, as they leave it on 8, it's
So
like
you can notice that there's
to
a
go
whole
away.
lot more air, basically.
And that's only people do.
Isn't that cool?
Isn't that so cool?
I'm looking over from that side.
Because we decreased from a PEEP of 3 to a PEEP of 8.
Look at
so
that.
this is exactly what we want. We want all those air sacs to be working together, but then
They'll
we've
show.
gotten the patient where we want them to be, and we've gotten the oxygenation.
They'll show a break in
but
the
now we
circuit
need to
and
break
watch what
that
happens when
ventilator
we
circuit.
break
Either
the
give some
circuit
medication
in a little
or
bit.
to change the ventilator circuit. And then what happens is we get this huge deep recruitment
See?
of alveoli.
That was
It's
just like
breaths,
taking
just
the,
long enough
disconnecting
to
the
open
circuit
that
for a second.
And it takes a few breaths just to get back up to where we were, let alone any kind of therapeutic heat.
But even with the break, that the like black area didn't come back.
Yeah, but you lose
Yeah, you
all
see
of
it,
it.
yeah.
So how cool is that? I think that's so cool.
That's cool.
Yeah.
Because we put our patients on the ventilator and they'll be, like in the unit, it's nothing to see a patient of people 15, right?
And they're on high PEEP, you can't.
Yeah, so we'll see a people like 15 or something like that, and we'll say, well, I'm just gonna break the circuit to do this or that, or I'm just gonna break the circuit because I'm transporting them and putting them on the other ventilator, you know. Oh, well, let's move, we're gonna move the IV pole, so can you just disconnect a second while we, you know, put the tubing this way or whatever. So every time we do that, we're recruiting everything that just happened.
For some patients, that's not a huge deal, but for which patients, like it could be a huge deal what their PEEP is, depending on what their PEEP is. So you
And
just
that's
have to think about that.
That's also why it's safer for us to transport from the ventilator than bagging also, because we can maintain that circuit. I mean, we are switching to put them onto the different one. We know how much PEEP they're getting exactly. We know that they're staying on that circuit the whole time, other than like bagging down to CAT scan, putting them on the CAT scan ventilator, disconnecting to put them back on the bag, bagging back up, putting them back on. So that's saving several disconnects by just putting them on the transport bed, taking them down and bringing them up. So we always have to keep that stuff in mind. So when we're bagging a patient, there are some patients we can bag, you know, during an emergency situation or whatever. They'll be fine with no PEEP. However, if we at least put like a PEEP of 5 or something on them, it's going to make a total difference, and we can get their sats up much quicker. Plus, especially if it's a patient that we are getting ready to intubate, wouldn't you much rather have those lungs ready and good and filled with air and, you know, good oxygenated blood circulating before we're going to, you know, give the patient those medications and put the tube in, because, you know, a lot of stuff happens during that time. So we want to have our patient as stable and good to go as possible before we do anything.
That PEEP valve that you put in the bag, is it like with new babies, with newborns, where when you apply pressure with the mask, it automatically puts a PEEP of 5, and then when you
No, it's not like the manometer thing. So,
and you make the PEEP?
You just turn.
You just turn it?
Yeah. So you can pass this around, but it just turns, and there's numbers on here. They'll tell you, and the one that's on the bag, I think it's the same thing. You just turn it down, and it'll.
And so it'll keep the lungs inflated?
Yep.
In our new ambu bags, the PEEP valve is identical to that. It's just like a different color, like all the settings and the turning.
It stays on the new one?
It comes on it, so you don't have to add it.
Which is awesome.
It's great.
We'll be using it.
It's just going to skip a step, but the functionality is the exact same. You'll turn it the same direction, like it's all the same.
Julie, this maybe, I don't know if this is stupid comparison, but could I compare PEEP to like ailment in the cells, say create a buffer in the cells and prevent it from collapsing or whatever? It would be kind of same.
Maybe. I mean, PEEP is the amount of pressure left in the lungs at the end of expiration, right? So when we exhale, how much pressure is left in the circuit.
To prevent it from collapse.
To prevent from collapse when you're at the end of your exhale.
And that's like
yeah. I've never heard that before, but
never. But I mean, I'm thinking,
okay.
if you have enough albumin in the cell, it kind of prevents it from collapsing, pushing out all the.
So I guess,
kind of the same thing. You know what I mean? That's what I do.
Yeah, I think of it like the babies, because that's where I learned to pee.
Yeah.
But when a newborn baby's born, their lungs sometimes are collapsed, so if you don't keep that PEEP, their lung will just recollapse every time you exhale. So they just think of that PEEP is just keeping their lungs open. It's like a balloon. Instead of deflating a balloon completely, you're inflating and then deflating to a certain point. So
yeah, babies a lot of times, like, you have to give them PEEP when they're first born. And that's all you have to do is put a mask with a little PEEP and then they're fine. But after like a few minutes, it's not exactly, their lungs just keep, that's a good thing to see, like a balloon. Instead of the balloon going all the way down and then open again, all the way down, open again. It's much easier.
Yeah,
like, it's much, if you're the person blowing up the balloon, it's much easier for you.
Now, what level of PEEP are we going to be starting to be concerned of, like, increased intrathoracic pressure, like causing like tamponade?
So there's an ARDSNet protocol, and if you go on ARDSNet, I think it's ardsnet.com or something like that, we follow this protocol.
Okay.
And they'll either tell us they want the high PEEP, low FiO2, or the low PEEP, high FiO2 first. And we follow that.
Okay.
So it'll be dependent upon the person, the patient, and the provider. And there's a chart that we follow, and it's every couple hours that you make changes to it. But if you're on a PEEP of like 20 or so, again, you're watching pressures and that sort of thing. And you don't, I mean, the quicker we can get the PEEP down, the better, of course, with anybody. You know, PEEP of 20 or whatever is a lot of pressure. But you also want to benefit outweighs risk. Is it ARDSNet?
Yeah, .org.
.org. Okay. Yes. That also has like some training information on it. It has like our little charts on every ventilator. We have a little chart that tells us what our tidal volume will be. We give the patient's height, and then we just look across there. Usually we'll say 6 mLs. And so we look right down and it tells us what tidal volume we're going to put the patient on. So that's kind of the stuff that we do, just so that we're not just guessing at things. Like we actually have, you know, a method behind the things that we're doing.
The higher the PEEP, then that tells you the patient is sicker, the lung is sicker. The less that means that
PEEP is for oxygenation for the most part.
Yeah.
Yeah. So we've talked a little bit about PEEP inspiratory pressures.
Can I add one more thing? Sorry. So what's the lowest PEEP you've ever seen? What do we usually say as a minimum? So why do we leave a PEEP of 5? Why not 0?
Because the lungs don't collapse. So that doesn't happen. What happened when they deconnected? So the lungs don't go down.
Well, they say that a PEEP of 5 is just enough PEEP to help the patient feel like they're not breathing through a straw all the time. It's just enough because that airway is much smaller, right? Because my airway right now is much bigger than 6 millimeters or 7 millimeters, right? So just that small amount of PEEP is enough to, and I've heard it said many times that it's just enough that the patient is not feeling like they're struggling to breathe through a smaller surface. So that's why we're not seeing PEEPs of 0. Typically, I won't say you'll never ever see that. You may, but usually if someone's on minimal support, 5/5, pressure support of 5 and PEEP of 5, typically there'll be rare instances where they'll go lower than that, but
typically when we're getting ready to extubate somebody, when they'll want to see a PEEP of 0, we'll do 0 or 0. It's usually a cardiac patient, and they'll do that to make sure that the PEEP wasn't keeping them from going into pulmonary edema or something like that. So they'll switch them to 0 or 0 for a short time just to make sure the patient's going to be okay off of the PEEP.
yeah, and it can, Tyler, like you mentioned, it can cause a decrease in venous return to the heart if it increases your thoracic pressure and your intra-abdominal pressure. It could potentially decrease venous return by putting pressure on the inferior vena cava. So if respiratory just came around and made a vent change for your patient and the PEEP's really high and all of a sudden they get hypotensive, that could be why. So again, now you're in a situation where we need to probably call the provider and see, is oxygenation our main priority right now and we're willing to put the patient on pressors to make up for that, or can we decrease PEEP a little bit and not put the patient on pressors, and so sometimes it's that balance, but that's usually when you're talking higher, 15, maybe 10 to 15, 20 definitely. When you're talking about those kind of PEEPs, you may see it impact your blood pressure.
And we are
that's
a little bit more cautious, like if someone has a lower pressure, about just bumping it up, without really having a conversation with the provider. Even if the provider has said you can go up to whatever, if the pressure is softer, then we will definitely have a conversation and say, hey, this is what they're saying, you still want me to go over, are you okay? Or whatever. Good? Yeah. Okay. So we've talked about some peak inspiratory pressure. So these are the alarms on the ventilator. Airway pressure exceeds preset upper pressure limit. Alarm may also read PAW high for high peak airway pressure. Possible causes. We've talked about a lot of this. Blocked and kinked tubing. You might have to drain condensation from the tubing. Mucus plug or secretion due to suctioning. Patient coughing and fighting the ventilator. Suction. You might need a different mode of ventilation. You might need sedation. If the patient is biting the ET tube, we might have to put a bite block or more sedation. Decreased lung compliance. You may need a neb. We might need the doctor. So what happens if the alarm is just alarming, and no matter what you do, you can't get the stop alarming? What are you going to do? Okay, respiratory comes and we try and we just can't get it to stop. Respiratory therapist just says, I don't know what to do.
Try maybe change diagram, change the machine.
Okay, good. You can diagram, yeah. What else? Who are we going to contact? The provider. So we're going to contact the provider. We want to have a huddle with the provider, the nurse, and the respiratory therapist. We want to discuss what we've tried, what's going on, did the ventilator's alarming, and then what do you want to do besides care for your patient? What do you want to do in regards to that conversation?
Document
that conversation, right? We've had cases where alarms have gone on and on and on and on, and you get tired of hearing the alarms, right? You're like, that patient has been alarming all day. We would like to think that no one does that or says that or thinks that, but it happens, right? The patient is on whatever machine, and the machine has been alarming all day. And you're busy with your other patient, or there's an emergency somewhere, and you're like, oh, that patient's been alarming all day. It's whatever. Well, then you go in that room, and the patient's been disconnected from the ventilator all that time. So we have to make sure that we're not getting alarm fatigue, that the alarms are on all these machines for a reason. And yes, it can be pesky. Yes, sometimes you think, oh my gosh, if this alarm goes off one more time, I just want to throw the whole thing out the window. But keep in mind why we're here, and that the alarms are there for a reason to tell us something, right? So we have to try to fix whatever the reason is. So if it's a patient that's just alarming, if between nursing and respiratory we can't figure it out together, we have to get the provider involved, really try to figure out the situation, and then document what we've done, the conversations we've had, and what steps we've taken to try to fix the issue, okay? Expiratory minute volume low acts as a patient disconnect alarm. So possible causes and how to troubleshoot: low spontaneous breathing. So especially like someone that's on pressure support, if they stop breathing, it might go off. Someone that you have to minimize their sedation, try to wake them up or switch modes. In pressure support, if they're on not breathing, it may say no patient effort, and it should flip back to a backup rate at that point. Cuff leak. So if there's a big cuff leak or any type of leak, where else would there be a leak?
Tubing.
Right.
That's one thing I always say when you go in, check where your tubings belong, because when you go in and it's hanging, you're like, where does this go?
Right.
Yeah. So it's always good to pay attention when it's hooked up correctly.
Right, your
So
tubing,
when you go
your-
in,
one of the heater wires could be
I mean,
off.
and when you're in a panic mode, you're not,
Usually you can hear the air.
the worst.
Usually you just listen for where you can hear the air blowing, and usually there's not supposed to be air blowing.
Yeah, then you
So
start the
just
patient, right, you
connect
start
that
the patient
piece.
and you just start working your way, right?
Follow your way.
Yeah.
Where is it spraying you? Where is
Yeah.
the air blowing?
Where are you going, cool breeze?
Yeah.
Start the patient and trace the vent tubing back to the ventilator, fix any disconnections. Alarm may also recheck tubing. So I guess one of the things that's a little bit frustrating too is that there's all these different words that mean the same thing. So just keep that in mind too. Circuit disconnections, start the patient again and look all the way back and fix any disconnections. Keep in mind that if it says like ventilator disconnected or something like that, that doesn't always mean it's the patient, right? That could mean that the tubing is disconnected from anywhere. The tubing could be disconnected from the ventilator, from the heater. That just part of the tubing could be disconnected. Expiratory minute volume high, increased patient activity or breathing anxiety, assess the patient and possibly switch modes or give sedation if appropriate. Respiratory rate high, same thing, anxiety, pain. You know, we have to be very mindful of pain. Patients are intubated, sometimes they can't really speak to us very well, and we always have to be mindful, you know, they have this tube in their throat, a lot of times they have other issues going on. You know, are these alarms going off because the patient is in pain? Ventilator self-triggering, check for disconnect.
Sorry, the expiratory minute volume high, is that when they're doing, like what they say, they're double stacking their breaths or stacking their breaths? Is that the alarm that goes off?
It could be that one. Sometimes it's going to be like the high respiratory rate will go off on that one also because it's going to count 2 breaths even though it's just 1. Sometimes there's a low rate that will go off because one breath is going to be super high and the next breath is going to be volume is going to be super high and the next volume is going to be super low. So that will go up, and a lot of times the peak pressure will go up on that one too, depending on how they're stacking. So in a lot of like one issue could cause several alarms to go off too. If you look at the ventilator, sometimes you'll see where a whole list of alarms have been going off, and that's why. So the low peak disconnect, start the patient again and trace back, a cuff leak, or if the ET tube is misplaced. What's something that could indicate to you that the ET tube has come dislodged?
A different number.
Is it a different number?
Different alarm.
What's going to be alarming besides the ventilator? End tidal, exactly. The end tidal is going to go to 0 if the tube comes out. So I always talk about this when comparing like SATs to end tidal. But how many of you have been in an apnea test? Have you guys done an apnea test with this yet?
For Living Legacy.
For Living Legacy? No. So when we do an apnea test for Living Legacy, or to, you know, prove brain death with a patient, what we do is we get a blood gas, and then we take the patient off the ventilator and put oxygen down the tube at like 5 or 6 liters. Then for 10 minutes, you wait to make sure there's no spontaneous breathing by the patient. At the end of the 10 minutes, we draw another blood gas and then we put them back on the ventilator. So for 10 minutes, the patient does not breathe at all. What do you think happens with the SATs and what do you think happens with the end tidal? The end tidal immediately goes to 0, right? Because there's no breaths. So instantly the end tidal goes to 0. What do you think happens to the SATs? Funny enough, they hardly move. The patient's not breathing, but they hardly move. They may drop a little bit, but if the patient like started in the mid-90s or so, they usually hardly ever drop out of the 90s. It takes that long for they have oxygen, they're still getting a little bit of oxygen. The patient's heart is still beating, they're just not breathing, right? So you can't rely on pulse ox to tell you a patient's not breathing. So especially a patient that is not on a ventilator, that it just has the end tidal, the nasal end tidal, that like say it's a surgical patient, or a patient that's had, you know, for whatever reason had too many narcotics, you know, maybe they just came from the OR, or maybe it's an overdose patient or something like that. When you hear that end tidal beeping, you want to check it out, because that's going to tell you the story way before the pulse ox is going to tell you the story. And it can alarm a good bit for different reasons, but that's another thing we need to figure out why. Does the patient need a CPAP? Do they need to have their sedation decrease? You know, what is the story? We can't just say, wake up, take another breath, wake up, take another breath. You know, that's not the answer. We really need to figure out what's causing the thing to alarm. And we can, on all of our machines, basically everything is a computer. So you can go back and look at trends on anything and see, you know, how long the patient had been either low respiratory rate, desatting, anything like that. And it'll tell us on the end-tidal machines. Okay. The heater alarm, oh, it's such an annoying little
chirp thing.
Yes. So the heater can alarm if the bag is empty, if it's not turned off and we go on transport. Sometimes the little probes just get wet and we have to wipe them with alcohol or something like that. And sometimes if you just simply turn it off and turn it back on, then it's fixed. The capno alarm dysfunction, if no reading or flatline, we can set up a new one. Sometimes they get wet and just need to be changed out. So remember, don't panic. Never ignore alarms or silence alarms. Solve the problem and call for help. When in doubt, what do? Agitation. Ventilator alarms are attached to the call system on 4 West. Alarms are heard at the nurse's station. Why?
So people can go, how, I mean, so everybody knows there's something.
Right.
Hopefully somebody will respond.
Exactly. Watch the ventilator tubing when turning and moving your patient. Just make sure there's plenty of slack. Do not place liquids on top of the ventilator, please. It's a computer. If issue alarm is unresolved after collaboration with RN and RT, call RN, RT, and be huddle to address the issue and be sure to document. So this is the ventilator screen. Does anyone know which settings are that we have set on the machine that the machine is going to deliver?
Pressure and volume.
All right, so the PRVC,
Yeah, I was gonna say.
and then the ones along the bottom are the set tidal volume 320, the set rate is 14, the PEEP is 10, and FO2 is 15. Then along this side is what the patient is doing, okay? So we've talked about the peak pressure a lot. So what is the peak pressure on this patient? 20, right? The respiratory rate is 15, and then the tidal volume, usually look at this bottom one, it's 306, okay? Waveform capnography, we've talked about a little bit on and off. It measures the CO2 in the airways, provides a breath-to-breath status, and will show immediate apnea. Okay. Alarm limits are set by respiratory. If you have a patient, like a lot of times athletes or runners will have a lower heart rate, don't let that keep alarming. Let us know, we can adjust the heart rate alarm for a patient. If you have a CO2 patient that normally has really high CO2, we can come and adjust that appropriate to the patient. You know, we don't want nuisance alarms just to be annoying. So those alarms can be adjusted. Contact respiratory therapy, if the alarms continue, our default alarms are CO2 of 60 and low of 8, respiratory rate high of 50, low of 6, 80% for the low sats, and 50 for the low heart rate. So sometimes they do need to be adjusted. A few reminders about suctioning. We have the inline suctions when they're on the ventilator, the Ballard for trach and ET tube, suction regulator, 100 for Ballard nasal suctioning and Yanker suctioning, and 30 for the subglottic suctioning. If you're suctioning a trach and they're not on the ventilator, be mindful, because the regular suction catheter is about this long, the trach one is about this long. So when you're using the kits that you pull from the pods, they're going to have a suction catheter that's regular size. So make sure that you're not shoving that whole thing down there. What should you do when you're suctioning? Stop when? When you feel resistance, when they're coughing and bringing up a lot of secretions, things like that, okay? So you never want to force it. Julie?
Documentation and epic. Yeah. The RN mechanical ventilation flow sheet. Are you guys familiar with documenting this Q shift? There's an RN mechanical ventilation flow sheet where you can document your FiO2, your respiratory rate, set respiratory rate, and then your patient's actual respiratory rate, and then their tidal volume, which is just good to eyeball. You should always be getting that information in a report, what your settings are, and then you should, of course, be paying attention if hopefully respiratory therapy will let you know if they're making adjustments, but you always want to be on top of that so you know if your patient's vital signs are changing or respiratory rates changing. Is it because they're on the pressure support trial now? You know, are my orders changing? You know, those should populate for you to see as well. So we just want to make sure that we're eyeballing that and documenting it just once a shift with any changes. So you can also wrench in. What's the name of the flow sheet that you use?
It's just ventilator flow sheet.
Ventilator
we
flow
have
sheet.
a BiPap flow sheet.
Ventilator flow sheet. So this is another thing that I've noticed staff don't all know about. If you want to look at respiratory therapy's flow sheet so that you can look minute by minute for any time they make changes when they fill out their entire flow sheet or they're doing vent checks and documenting settings, you are able to wrench in the ventilator flow sheet and view everything that they're documenting as well, which I think could be good to look at. Okay, it's 9:52, my patient has, you know, is failing their pressure support trial. I can look back and see that they went on at 6:52. They've tolerated 3 hours. Okay, that's good for me to know without ever tracking down RT. You're able to kind of look at that. So that's another thing. You should not be documenting there. That's for respiratory, but you can view it.
If there wasn't a conversation for some reason,
Yeah.
if you were off the floor or whatever, and the patient failed their weaning trial, there should be documentation in that flow sheet row that says the time it was started, the time it was stopped, the reason it was stopped.
Yeah.
It's at the bottom of the flow sheet, but that's all in there too.
Your RSBI, right? All of
Yeah.
that. So that's another thing in your toolbox.
Yeah, I have a lot of nursing stuff in mine. I have like the nursing handoff report. I
Yeah,
have nursing,
it's just
all
good
kind
to
of
view.
stuff because it's makes it a lot easier sometimes when I'm going to do, you know, spirometries on patients that I've never seen before that aren't even in respiratory care or whatever. So you can always, you know, feed back and forth off of each other's documentation a little bit. I'm sorry?
It's just in the flow sheet.
Yep, it's just in the flow sheet because sometimes, especially when they're using like a spontaneous breathing trial protocol, like they may not have orders for all of that at that point, you know. So it's harder to just follow order. Or if there's an acute decompensation, they're not going to insist that there's an order before they make the change. So, I mean, you could probably speak to this better than I could, but you would agree that your flow sheet would be more up to date than any
Absolutely.
orders, right?
Absolutely.
So if you wanted real time,
Yeah.
most of it's in the flow
Sometimes
sheet in real before they even leave the room.
We could get a verbal order and just do it, and it's not in there,
Exactly.
something like that.
It's just like kind of finding it because we are like the way our Epic is set up is different than the
I can show you
Yeah.
if you. Yep,
Yeah,
just grab
I
it.
could probably show you too.
Yeah. So name the 3 ventilator modes that could be used for a patient who was completely sedated.
There's only one wrong answer. What's the wrong answer?
Yep. Your patient's ventilation orders are as follows. Volume control, rate 14, tidal volume 400, PEEP 5, 40%. Please explain what happens when your patient takes a spontaneous breath on this ventilator setting. They're going to get the same tidal volume.
Yeah.
Exactly. Your patient's ventilation orders are as follows. Pressure support 5, PEEP 5, 40%. Your patient has increased work of breathing and has been taking the entitled breaths of approximately 100 for the past 20 minutes. What should your next steps be?
Call respiratory. Probably go back to their stuff.
The other one.
Yeah, exactly. So the patient's not tolerating it, so they would want to go back on their support mode.
Failed SPT.
Yeah, exactly. Name 2 possible causes of high peak pressure alarm.
Vitamin 2.
Biting, coughing, secretion. Yep. Your patient's ventilator is alarming with a low peak pressure. We check for disconnection in the ventilator tubing or displaced eating tube, and both seem to be intact. The alarm continues. What should be the next steps? That's when in doubt, always. Yep. Is everyone okay with that?
Call respiratory.
No, before you call respiratory.
Light suction?
Might be a leak in
No.
She said bag the patient.
Oh, yeah.
Yeah, she said bag the patient. Whatever's just looking, everyone's okay with that? Okay. We'll go at, over all the equipment in a few minutes, but so with our department, we have 3 resource therapists. It's myself, Paula, and Tim. One of us are usually here every day, and we're on 4960. At night, the night shift supervisors carry that same phone, and that's Angela, Ashley, and Ryan. During the day, Jerry is here. He's the assistant director of respiratory, and he's also responsible for the blood gas lab. And then Sandy is our director, and you can call them anytime if there's ever any issues. We typically have about 70 therapists in our department. On day shift, there's anywhere between usually 7 and 9, plus the resource therapist, and at night anywhere between overnight time we go as low as 6. Just so you guys kind of have an idea of how our department works. In CCW, we usually have 2 or 3 therapists assigned there, but those therapists are also assigned to the nursery, mother baby, the surgery center, cath lab, so some other areas too. On 4 West, lately we've had 2 therapists on 4 West.
Great, yes.
But
I love that one, there's 2.
4 West has been very, very heavy lately. Actually heavier than CCW on some days for us recently. But there could be one therapist that has 4 West plus 4 South or something like that, especially at night. Sometimes the therapists have a couple different floors. So if you can ever not get in touch, or the schedule is on the internet, you should be able to find the therapist list there. You can always call 4960 if you need backup or help, but we're available 24/7, of course. You guys have any questions before we get to those machines? No? All right, let's take a 10-minute break, and then we'll get to the machines.